Imagine spending like tens of thousands of dollars and agonizing months of physical recovery to meticulously rebuild the foundation of this historic home.
Right, you get all the structural beams perfectly aligned.
Exactly. Everything is pristine, it's stable, and then on day one, you literally invite a wrecking ball into the living room.
Which is a terrifying image, but, according to specialists in urogynecology, if you undergo a vaginal tightening surgery or a prolapse repair and then carry another pregnancy, that is essentially the physiological equivalent of what you're doing to your body.
It's crazy. You're caught in this massive tension between recovering your physical comfort today and the biological reality of planning your family tomorrow.
Yeah, and the clinical guidelines, especially the latest protocols from the NHS, University College London hospitals, and some specialized maternal clinics, they really highlight a fascinating conflict here.
Which brings us to the core question we are exploring in this deep dive, right? Like, can surgical tightening affect future childbirth?
Exactly. We are looking at how altering the pelvic floor structurally, whether that's a standard vaginoplasty or a complex reconstructive prolapse repair, how that fundamentally changes the biomechanics of a future childbirth.
And equally critical, how the sheer mechanical load of a future childbirth alters or just completely destroys the surgical repair you just endured.
The sources make it abundantly clear that it isn't a linear path.
No, not at all. So to understand the stakes of, like, surgically engineering our way out of pelvic floor dysfunction before a future pregnancy, we first have to look at what breaks the pelvic floor in the first place.
Because you really can't understand the repair without understanding the trauma.
Right. So think of the pelvic floor like a hammock made of heavily layered muscle and connective tissue. During a vaginal delivery, that hammock has to stretch dynamically to let the baby pass through.
And that stretching goes far beyond simple elasticity. When we look at maternal pelvic floor trauma, we're talking about severe mechanical failure of the levator ani.
Those are the shelf-like muscles that form the core of that hammock.
Right. Exactly. And as the fetal head descends, the levator ani are stretched to just extreme limits. In many cases, the strain is so immense that the muscle fibers physically shear away from the pubic bone.
Oh, wow. So they actually detach.
Yeah, it creates an avulsion. The muscle detaches from its anchor point, which fundamentally alters the structural integrity of the entire pelvic basin.
That sounds incredibly painful. Yeah. And on top of the muscle shearing, the sources highlight severe neurological impact too, specifically to the pudendal nerve.
Right, because if you have a prolonged second stage of labor or, mechanical interventions like forceps, you're applying sustained compression to those nerve pathways.
Add in episiotomies, which cut directly through those complex anatomical layers, and you have a perfect storm for denervation and structural collapse.
And that is the physiological origin of prolapse, where the bladder or rectum herniates into the vaginal space, and it causes severe incontinence. The trauma is really profound.
So it leaves the connective tissues fundamentally compromised, leading to that chronic sensation of vaginal laxity.
Yeah. The architectural support holding the pelvic organs in place has just been stretched beyond its yield point, and in many cases, physically severed.
Okay, so reading through all this direct mechanical destruction caused by the baby passing through the birth canal, a logical workaround kind of jumps out.
You think I know where you're going with this?
Right, if vaginal delivery causes this specific muscular and neurological shearing, wouldn't a planned C-section just be a total bypass of the trauma?
It seems like it would be.
Yeah, if you just go through the sunroof instead of forcing the garage doors open, the hammock should stay perfectly intact. Right?
Well, that is the assumption many patients operate under. But the maternal pelvic floor trauma guidelines introduce this really critical concept of the indirect injury of pregnancy itself.
Indirect injury. So just being pregnant causes damage.
Exactly. A C-section avoids the acute mechanical tearing of the birth canal, sure, but it completely ignores the 9-month physiological marathon that precedes it.
Because of the hormones.
Right. From the first trimester, the body produces high levels of hormones, predominantly relaxin. And relaxin's specific cellular function is to alter the collagen matrix in your body.
So it's basically systematically dismantling the structural rigidity of the hammock so the pelvis can eventually open.
Yes. It increases water content in the tissues and breaks down collagen fibers to make your ligaments highly compliant. It remodels the collagen.
Wow. So now you have a pelvic floor made of chemically softened, highly vulnerable tissue.
Exactly. And then you subject that softened tissue to a massive, continuously increasing gravitational load. You have the weight of the developing fetus, the placenta, the expanded uterus, the amniotic fluid, all pressing directly down onto the levator ani for months.
So even before labor begins, the hammock is sagging and sustaining microscopic damage under all that weight.
Yeah, the levator hiatus, that's the opening in the pelvic floor, it widens significantly during pregnancy, regardless of how the baby is ultimately delivered.
Even if that load is eventually lifted out from the top via C-section.
Furthermore, the clinical evidence definitively states that the protective effect of a C-section on the maternal pelvic floor only lasts for up to 2 deliveries.
Wait, really? Only 2?
Yes. If you have 3 or more pregnancies, the cumulative gravitational weight and the repeated hormonal remodeling of the collagen matrix will impact the pelvic floor just as severely as vaginal deliveries.
That is wild. The protective statistical difference just vanishes.
It does. And, this is before we even factor in the escalating inherent surgical risks of multiple C-sections, like severe abdominal adhesions, placental accreta, and uterine rupture.
Okay, so if that is the baseline reality of the damage, what happens when we try to medically intervene before the next pregnancy?
This is where we need to look at how surgically altering the vaginal canal or the structural supports of the uterus impacts a future birth.
Right, and looking at the clinical literature, we really have to separate these procedures by concept because the risks vary wildly depending on whether you're just tightening the canal or, like, manipulating the deep pelvic architecture.
Exactly. Let's look at standard vaginoplasties first.
Okay, so this is the removal of excess mucosal tissue, right? And suturing the muscles closer together to decrease the diameter of the canal.
Yes. With standard vaginoplasty, the primary intervention is on the vaginal mucosa and the superficial muscular layers. And clinically, this specific surgery does not physically impede conception.
Okay, so you can still get pregnant.
Yeah, nor does it inherently threaten the viability of the fetus during gestation. The surgical alteration is localized to the lower tract, so it doesn't introduce high-risk systemic factors to the pregnancy itself.
So the real danger with standard vaginoplasty isn't to the baby.
No, the danger is entirely to the structural integrity of the surgical repair, which we'll analyze in a minute.
Right, but the risk profile completely changes when we move away from superficial tightening and look at reconstructive prolapse repairs, like the Manchester repair.
Oh, absolutely. Because now we aren't just tightening tissue, we are amputating parts of the cervix and using ligaments to mechanically hoist the prolapsed uterus back up.
Which sounds intense. And the clinical warnings surrounding the Manchester repair in the context of future pregnancies are pretty severe, right?
Very severe. The cervix is a dynamic, highly specialized organ. It's designed to stay rigidly closed for 9 months and then dilate rapidly. When a surgeon performs a Manchester repair, they amputate the elongated portion of the cervix, which creates significant fibrotic scar tissue.
And scar tissue, by its biological nature, lacks the elasticity of native tissue.
Which leads to cervical stenosis. The scar tissue makes the cervix rigid.
I imagine that doesn't just make conception mechanically difficult, it fundamentally compromises the structural integrity needed to actually hold a pregnancy to term.
It introduces a massive vulnerability. The rigid, scarred cervix is highly prone to premature effacement. The fibrotic tissue simply can't withstand the increasing pressure of the growing fetus.
So that significantly escalates the risk of second trimester loss or premature labor.
Right, because you are relying on a surgically altered, scarred structure to perform a high-stress mechanical hold.
Wow. And the risks escalate even further with a sacrohysteropexy. That's where surgeons use synthetic mesh to pull the uterus up and anchor it to the sacrum, right?
Yes, and the guidelines from the British Society of Urogynecology state that if you have this mesh suspension, any future delivery is mandatorily a planned C-section.
It's an absolute contraindication for vaginal birth.
Completely. The synthetic mesh is integrated into the tissue to provide this rigid, permanent suspension bridge for the uterus.
So the sheer downward mechanical force of uterine contractions during labor, combined with the passage of the fetal head, it would violently tear the mesh from its anchor points on the sacrum.
Or rip it straight through the vaginal wall.
Yeah.
It would cause catastrophic failure of the repair and potentially severe internal hemorrhaging.
Which brings us to perhaps the most extreme procedure detailed in the sources from University College London hospitals, which is the bowel vaginoplasty.
Yes. This is for severe reconstructive needs where they actually harvest a segment of the intestine to create or lengthen the vaginal canal.
And the warnings from UCLH are incredibly strict here. I mean, a vaginal birth is absolutely impossible, obviously, because intestinal tissue lacks the specific cellular elasticity to accommodate a fetal head.
But the systemic risks to simply carrying the pregnancy are staggering. Because a bowel vaginoplasty is not just a pelvic surgery, it is a major abdominal surgery.
Because you're resecting a portion of the gastrointestinal tract.
Exactly. Anytime you cut into the bowel, you trigger a massive inflammatory response in the peritoneal cavity. The body produces this fibrinous exudate to heal the surgical site, which often turns into dense, fibrous bands known as adhesions.
And these adhesions essentially act like glue, right? They glue the internal organs together.
Yes. They can physically cement the delicate fallopian tubes to the abdominal wall or the bowel. This distorts their anatomy and paralyzes the ciliary motion required to move an egg into the uterus.
Which would drastically reduce fertility. And it creates a very high statistical probability of an ectopic pregnancy, right? Where the embryo implants in the damaged tube instead of the uterus.
Exactly. And UCLH anticipates high risks, even if the embryo does implant correctly. Late miscarriage, preterm labor, fetal growth restriction.
Because the abdominal cavity has been so anatomically distorted by the bowel resection that the environment is just inherently hostile to a developing fetus.
Right, the blood supply has been altered, the space is restricted by adhesions. It fundamentally changes the viability of the pregnancy.
So we've established that while conception is possible after these surgeries, the birth plan is drastically altered, often mandating really high-risk C-sections. But let's look at the inverse. What does the pregnancy do to the surgery?
This is a crucial question.
Because looking at the physics of it, getting a vaginoplasty and then getting pregnant seems like taking a stretched out, fatigued rubber band, snipping it, and sewing the ends tightly together.
Right, it feels tight in its resting state.
Yeah, but the moment you stretch it over watermelon again, those surgical threads are going to snap or like physically pull right through the compromised rubber.
That analogy perfectly illustrates the core problem outlined by the Women's Health Clinic and the Center for Surgery. The medical concept here is the dynamic pelvic floor.
Meaning it's not just a fixed object.
Right. Patients often conceptualize surgery as a static, permanent fix. You break a femur, a surgeon secures it with a titanium plate, the bone calcifies, and it is permanently fixed.
But the pelvic floor is a dynamic, load-bearing hammock.
Exactly. It is in a state of continuous adaptation to mechanical strain, intra-abdominal pressure, weight fluctuations, and endocrine shifts.
It's living responsive tissue, not a rigid titanium plate.
Precisely. So when a surgeon performs a vaginoplasty, they identify the stretched, separated levator ani muscles, pull them back to the midline, trim the excess lax mucosa, and suture it tightly.
But the underlying cellular quality of that connective tissue, the collagen matrix that was damaged in the first place, it remains unchanged, right?
Yes. It's still the same vulnerable tissue, just pulled tighter. So when you introduce a new pregnancy, you flood that surgically tightened tissue with relaxin once again.
Oh, right. So you artificially soften the sutured muscles and then apply the massive, escalating downward weight of the uterus for 9 months.
And the mechanical load of the pregnancy causes these surgically repaired levator ani muscles to separate right back to their pre-surgery state. The sutures can literally pull through the chemically softened tissue.
Wow. So all the excess mucosal tissue they trimmed away is gone, but the underlying muscular support just collapses again.
And if you attempt a vaginal delivery on a standard vaginoplasty, the acute trauma of the fetal head will absolutely obliterate the surgical repair.
But the clinical consensus explicitly warns that even if you bypass labor entirely with a planned C-section, the 9 months of dynamic gestational strain alone is enough to completely negate the tightening, isn't it?
It is. The symptoms of severe laxity, the urinary incontinence, the sensation of prolapse, the exact pathologies you paid to have surgically corrected will very likely return in full force.
That is just, it's a devastating cycle. You go through the immense physical pain, the surgical risks, the 6 weeks of movement restriction, and the massive financial cost, only to require a repeat operation to achieve the exact same baseline you had just recovered.
Exactly. It's a massive physical and emotional toll.
So if pregnancy destroys the surgery, and the surgery introduces massive complications to a pregnancy, what is the strategic path forward? Like, how are you supposed to manage a severely compromised quality of life if you aren't 100% certain your family planning is complete?
Well, the clinical guidelines from these specialist centers provide a very specific strategic timeline to prevent patients from falling into this surgical trap.
Okay, what's the first step?
The absolute first step is strict physiological observation. Clinics mandate waiting a minimum of 6 to 12 months postpartum before even attempting to assess baseline laxity.
Because the collagen matrix takes that long to stop remodeling and restabilize after the relaxin leaves the system, right?
Exactly. The tissues undergo natural contracture and recovery, but there is a secondary vital caveat regarding the endocrine system, and that's breastfeeding.
Right, I was looking at this in the sources. You can't accurately assess the need for a vaginoplasty until you're at least 3 months post-breastfeeding.
Yes, and the mechanism here is fascinating. Prolactin, the hormone that stimulates milk production, actively suppresses estrogen.
And estrogen is the hormone responsible for maintaining the thickness, elasticity, and hydration of the vaginal mucosa.
Right, so breastfeeding is essentially creating a temporary, localized menopausal state in the vagina.
That makes so much sense. The low estrogen causes mucosal atrophy. The vaginal walls become thin, dry, and they lose their rugae, those natural folds that provide friction and tone.
That is the exact mechanism. This temporary atrophic state perfectly mimics the symptoms of structural laxity or prolapse, and frequently causes severe dyspareunia or pain during intercourse.
So if a surgeon evaluates you during this phase, the tissue looks and feels severely compromised, even if it's just hormonal.
Exactly. But once breastfeeding ceases, the ovarian cycle resumes, estrogen levels rebound, the mucosa revascularizes and plumps back up, and the perceived severe laxity often resolves completely on its own.
Okay, so you wait the full year, you finish breastfeeding, estrogen rebounds, but the structural damage is still there. The muscle avulsion is real. But you know you want another baby in, say, 3 years.
In that case, the overwhelming consensus from the clinics is a hard stop on structural surgeries. Do not get the vaginoplasty. Do not get the Manchester repair.
Delaying surgery until the family is definitively complete is really the only clinically sound advice. Performing a reconstructive pelvic surgery on a patient who intends to carry another pregnancy is just medically counterproductive.
But the clinical literature doesn't just tell patients to suffer in silence for 3 years. There are interim, non-surgical alternatives to bridge that gap.
Like what?
The primary recommendation is intensive, targeted pelvic floor muscle training. And we aren't talking about generic Kegel exercises you read about in a magazine. We're talking about neuromuscular re-education with a specialized pelvic floor physical therapist.
Right, because it's about isolating the correct motor pathways. I read that many patients with levator avulsions compensate by contracting their glutes or abdominal muscles, which does nothing for the pelvic floor.
Actually, it increases intra-abdominal pressure, which can worsen a prolapse. A specialist uses biofeedback to train the remaining intact fibers of the levator ani to hypertrophy to physically grow thicker and stronger to compensate for the torn sections.
That's amazing. But when physical therapy reaches its functional limit, the sources also introduce energy devices as a bridge therapy, right? Specifically, radiofrequency treatments like the Votiva system.
Yes, they do.
When I first read about this in the clinic FAQs, it sounded almost like microwaving the vaginal tissue to tighten it, which frankly sounds terrifying. How does applying thermal energy safely create structural tightness without making incisions?
It sounds extreme, but it relies on the biological principles of wound healing and collagen denaturation. Radiofrequency devices deliver a controlled, highly specific alternating current into the submucosal layers of the vaginal wall.
And this current encounters resistance in the tissue, which generates thermal energy, heating the targeted layers to about 40 to 43 degrees Celsius.
Which is just enough heat to trigger a physiological response without causing a burn.
Exactly. At that precise temperature, the triple helix structure of the existing collagen fibers partially denatures, meaning the heat causes the fibers to instantly contract and thicken.
That provides an immediate, noticeable tightening of the mucosal lining. But the more profound mechanism happens over the following weeks.
Right, because the thermal injury triggers a natural wound healing cascade. The body deploys fibroblasts to the area, which synthesize brand new, tightly woven type I collagen and elastin. We call this neocollagenesis.
So because you are relying on thermal energy to trigger cellular regeneration rather than physically cutting and suturing muscle, you aren't leaving rigid scar tissue. You're just creating a thicker, tighter mucosal layer.
It improves the tissue tone and the mucosal integrity without altering the deep muscular architecture.
And because it doesn't leave fibrotic bands or surgically bind the muscles, it remains a highly flexible option for a patient who plans to conceive again.
Yeah, if a subsequent pregnancy stretches that tissue, you haven't destroyed a complex surgical reconstruction. You have simply stretched tissue that could be treated non-surgically once again.
That distinction makes complete sense.
So, to pull all these clinical realities together, Can you physically have children after a surgical tightening procedure? Yes. But it fundamentally alters the biomechanics of your future.
A reconstructive prolapse repair forces you into high-risk mandatory C-sections to prevent catastrophic structural failure.
And even if you only have a standard vaginoplasty, the sheer hormonal and gravitational reality of a 9-month pregnancy will stretch those repaired muscles right back out, negating the surgery entirely.
Timing the intervention really is the critical metric for success.
For you listening, this highlights why understanding the actual mechanisms of your own anatomy is so vital. When you understand that the pelvic floor is a living, dynamic hammock subjected to intense endocrine shifts, and not just a static structure waiting to be stitched up, you can align your symptom management with your family planning.
You don't have to operate on guesswork anymore. And looking at the trajectory of this field, the biological realities we've analyzed today point toward a massive shift in how we approach maternal health.
Because right now, we know exactly how severely the pelvic floor responds to relaxin, to mechanical load, and to the trauma of labor,
Yeah.
but we treat it retroactively.
We wait for the hammock to snap, and then we try to piece it back together.
But that's changing, right? With the integration of multi-onics into women's healthcare.
It's rapidly advancing. We are looking at the clinical ability to analyze a patient's specific genetic profile, analyzing their unique ratio of type 1 to type 3 collagen in their connective tissues.
It is highly probable that in the near future, a simple tissue analysis and a high-resolution 3D ultrasound could precisely predict a patient's exact biomechanical failure point before they even conceive.
So a specialist could look at your specific collagen matrix and know definitively if your pelvic floor is structurally capable of withstanding a vaginal delivery, or if an avulsion is statistically guaranteed.
We could move away from generalized guidelines and retroactive surgeries entirely. We could shift toward preventative, highly personalized tissue conditioning.
We could predict the trauma and engineer the birth plan to avoid the anatomical destruction before it happens.
A completely proactive paradigm for the pelvic floor, eliminating the need for these complex surgical dilemmas in the first place. That is an incredibly powerful frontier to watch. Well, until next time, keep looking past the surface answers and keep asking the hard questions about the mechanics of your health.